Namaste and very good afternoon to all. Myself, Dr. Chinmay Shah, working as Associate Professor, Department of Rognidan, ITRA, Jamnagar, welcomes you all. Respected today's our guest speaker, Dr. Ajantha Kotekar, sir. Respected our Darshana Pandya madam, other faculty members, and dear participants, I welcome you all. Today it gives me immense pleasure to welcome you all for the Pratipatti webinar series, episode number 5. I am truly honored to have such an eminent personality in the field of Ayurveda, Dr. Ajantha Sivaji Kotekar, who will deliver today's session. Now, moving towards the brief introduction of today's guest speaker. Dr. Ajantha is presently serving as the professor and head of the Department of Rognidan, Yenepoya Ayurveda Medical College and Hospital, a constituent unit of Yenepoya deemed to be University Mangalore. Dr. Ajantha holds an impressive academic background, having MD and PhD in Kai Chikitsa. Sir has also completed his PGDYN course from Gujarat Ayurveda University, Jamnagar. His research journey is remarkable, especially his extensive work on male infertility in both MD and PhD work, which has earned special recognition and expertise in this domain. Sir is having also 25 years of clinical experience, 18 years of UG teaching, and 13 years of PG teaching experience. Sir has authored and guided so many scholars with over 54 scientific publications. Sir has received several honors, including the SDM Guru Award, Good Teacher Award 2023, and Ayur Sir Research Award. With such vast experience and excellence, we are really privileged to have his insights on topic semen analysis with us today. On behalf of Rognidan Department, ITRA, I extend a warm welcome you, sir. I also welcome our HOD ma'am, Dr. Darshana Pandya madam. We look forward to an enriching and inspiring session. So I welcome you, sir. And one announcement is there. There will be question answer session at the end of the webinar, and participants also may raise their hand or put their query in the chat box. Thank you and welcome, sir. Ji, sir. Yeah. Sir, 1 minute. Yeah. 1 minute, sir. 1 minute.
Are my slides visible?
Yes, sir.
Am I clearly audible?
Yes, sir.
A very good afternoon. Respected Anup Thakur sir, most respected Pandya madam, and most respected Chinmay madam, and all the staff, PG uh, members, as well as all who are attending this particular seminar. Welcome to all. Now, this is one of the topic that is catching everybody's attention. That is because I'll tell you the different reasons why it is catching the attention of different people. All think in India there is plenty of population, there is population explosion. Why a topic like semen analysis is important? Semen analysis is important because it is connected to male infertility. Why male infertility is important when there is population explosion? So this is a very valid question, but I would like to bring it to your kind notice. The reference ranges for semen analysis in few of the years. If you look into that, then it becomes imperative. The volume which was considered to be normal among the seminal parameter, the seminal volume, which was 2 ml, has reduced in 2010. The WHO has reduced it to 1.5 ml. The count, which was 20 million per ml, which was considered normal, has reduced to 15 million. And when you look into the motility, previously it was said that about half of the sperm should be motile, that is rapid linear progression as well as slow linear progression. 50% if it is there, then it was considered to be normal, which is reduced to 32%. The vitality, that is the live sperm, which was more than 75 in 1999, is reduced to 58. And morphology, that is the normal sperms which should be present in the semen, which was 14%. Now it is reduced to 4. Now, by looking into all these parameters, it is quite imperative that the fertility potential of human male is deteriorating. If you look into the sperm count by different researches that has been done, which was around 66 million, previously has reduced now down to around 15 to 20 million per ml. In the sense, the fertility rate is getting compromised. And in the days to come, infertility, very particularly male infertility, will be a burning problem. Possibly when I was a student, there were no infertility centers, or maybe one or two here and there. But now, at the corner of every street in the cities, you find multiple infertility centers. So the condition is really very alarming. The fertility potential of human, particularly the males, is deteriorating day by day. Now, when I say infertility, this infertility is contributed by both male as well as the female partner. WHO says if a couple participate in unprotected sexual intercourse for more than 12 months, and if this unprotected sexual intercourse is regular, this is very important, regular, then even then, if they do not procure a child, or if they fail to achieve a pregnancy and a child, then such a condition is termed as infertility. It is very important when there is 12 months of regular unprotected sexual intercourse. It is very important to have this during the fertile period of the female partner. This is very key in achieving pregnancy. So whenever we talk about infertility, there are two terms. One is the primary infertility and second is the secondary infertility. Now this primary infertility is where a person fails to impregnate his wife, or the couples fail to get a child even after 12 months of unprotected sexual intercourse. They fail to get a child even a single time. That is identified as primary infertility. On the other hand, if the man can achieve one pregnancy, at least one pregnancy with the female or with the partner, and subsequently after that, when they are trying to achieve pregnancy, if they fail, then that is identified as secondary infertility. Nowadays, previously secondary infertility was prevalent, but nowadays primary infertility is a burning problem. The couple failed to get even a single child, and this is going to be devastating in the years to come. Therefore, this particular topic of semen analysis finds merit because when we start male infertility evaluation, the cornerstone of male infertility evaluation is semen analysis. It is quite imperative. Let us have a small, I'll give you a small problem. I want everyone in this particular group listening to close their eyes for 2 minutes, and I'll give you some instructions. You can go through those instructions, and then you can make out the importance. I hope I am audible to all. Am I audible? Am I clearly audible?
Yes, sir. Yes, sir.
All of you, please close your eyes. Now, wherever you're sitting, you can see your there are wonderful buildings. You have all what super ultra tech facilities. Now you think around 10 years back or 25 years back, how your surrounding was. Possibly you do not see those ultra tech facilities in and around you. Now you go 50 years back. Now you go 100 years back and try to visualize your surrounding. Possibly you don't see all that development in and around you. Now you go 1,000 years back. Imagine 1,000 years back, the place around you. Try to identify the morphology of that place. Try to identify the place, how it would look like. Now think 5,000 years back. This is very important. 5,000 years back, how the surrounding, wherever you're sitting, how it would have been. It is no doubt, if I was given this problem, then it would seem that there is forest in and around. There are no buildings, maybe here and there one hut, wild animals, no human beings, very less, very scarce. And possibly some may think the human beings are wearing leaves or the hide of the skin of the animals, living in caves. So you see a sort of very primitive uh, surrounding around you. But why this exercise has been done? To make us understand that even when we think that it was only jungles in and around, no technology development, we think human beings are not very civilized. At that point of time, Ayurveda was documented. And Ayurveda was prevalent since thousands of years or since time immemorial, Brahma Spritva Ayurvedam, but it was documented at least 5,000 years back. And when we try to visualize that, we see that there is no technology in and around. Why I'm making this particular statement? Because at that point of time, what has been documented in Ayurveda is very scientific, which we will try to explore in the Semen analysis in these days, which is quite true. So at that point of time, when Charaka Samhita was documented or Shushruta Samhita was documented and later Vagbeta was documented, you can
Hello.
audible? Am I audible? Just a minute, madam. Is the screen visible now? Yeah, that I'll increase, madam. Am I visible now? Where was I audible, madam, last time? This one, Semen Analysis. This one, madam. Shuddha Shukra Lakshana. No, is it visible now? Is it visible now? Madam, now? Okay. Now it's visible? Yes, madam. If I get disconnected, please give me a call, madam. Yes. Thank you. So in the beginning, I said I gave a small problem that we'll all close the eyes and we'll think what is in our surrounding about 50 years back, 100 years back, 5,000 years back. And I said about 5,000 years back, we see only jungles and forest, very few people, less civilization, no technology. And what is quite interesting in Ayurveda is that we find the Charaka Samhita, Shruta Samhita, etc., documented 5,000 years back, where different attributes connected to Shukra was told, which is very scientific even today. As far as Charaka, he says it is made out of all Mahabhuta except Akasha, and it has got Shadrasa. As you all know, Shushruta says the color is Patikaba, it is Snigdha, it has got Snigdha Guna, Madhur Rasa, Madhugandhi. And here, with respect to smell, he says Madhugandhi. Today, in modern Semen Analysis, we say Madhugandhi, the smell is like chestnut flower. And when it comes to the consistency, they are given three consistency. It is Taila, or it could be Kshaudra. And when as far as Ashtanga Hridaya is considered, he says either it is Grita, Makshika, or Taila. In the sense, the semen could have different consistencies. It may not have the same consistency. So these should be considered as physiological limits. In the sense, we'll try to evaluate all this in the modern semen analysis as we go forward. Whenever we talk about the semen, most of the people think the semen is a product from the testicles. That is a wrong notion. From the testicle, it is only the sperm that is being produced, and little amount of secretion from the epididymis can mix and can come through the vas deferens and of the whole semen, this is only 5%. This is very important information all should remember in their clinical practice. Only 5% of the whole semen is been contributed by the testis as well as the epididymis. Then rest of the 95%, it has been contributed by the seminal vesicles, the prostate and bulbourethral gland. So this is very important. And in the seminal vesicle, the fluid that has been secreted, it is alkaline in nature. This is very important. Please note down, it is alkaline in nature. And most of the volume of the semen, about 80% of the semen is contributed by the seminal vesicle secretion. Therefore, large amount of seminal vesicle secretion will make the semen alkaline. And in the seminal vesicle, the secretion, there is fructose. Again, in the shloka we saw that, or in the Ayurveda information we saw that it is Madhugandhi, it is Madhura, etc. We have in seminal vesicle fructose. And this fructose is very important as it gives energy that is required for the sperms for motility. And also there are prostaglandins, and these prostaglandins are also very important because they help for the movement of the sperm for penetrating the cervical mucus. So 80% would be seminal vesicle secretion, 5% from the testis and the epididymis, and around 20% is from the prostate. And this prostatic fluid is acidic. Seminal vesicle fluid was alkaline, prostatic fluid is acidic. And when these two mix together, a pH is formed which is between 7.1 to 8. And this prostatic fluid has got acid phosphatase, citric acid, and it has got proteolytic enzyme. This is very important because the 80% of the secretion from the seminal vesicle is very thick. It is very thick and we call it as a coagulum. And this thick seminal vesicle fluid, which is alkaline, is broken down and it is liquefied by this proteolytic enzyme, which has been secreted by the prostate gland. So this is very important because later when we go through the semen analysis, if the semen is not getting liquefied, then the problem may be the prostatic fluid has not reached the semen. There could be some blockage. This is the understanding. Therefore, for proper liquefaction, prostatic fluid is very important. Only if the semen becomes liquefied, then the sperms can move in it. Otherwise, the motility of the sperm will be hampered and may result in infertility. Apart from this, the bulbourethral glands, they secrete around 5% of the secretions. And this is rich in mucoproteins and this lubricates the urethra. One point that is very important with bulbourethral gland is that they contain the secretions which has got anti-sperm antibodies. And this anti-sperm antibodies, if they are present, then there could be agglutination. The sperms will stick one to another. I'll show you all this in the later slides. And when this agglutination occurs, there will be infertility and they cannot get a child. So this is a basic. So always don't people think the whole semen is produced in the testis. No, it is only 5% from the testis. So you can see here, testis and epididymis of the whole ejaculate, the contribution is only 5%. Whereas seminal vesicle, it is around 70%, bulbourethral gland is around 5%, and prostate gland it is 20%. So highest material that you see in the semen would be seminal vesicle secretion. Next is prostate gland, very meagerly from the testis and epididymis and bulbourethral glands. So what is semen analysis? Semen analysis is a method of assessing the semen of a male and evaluating various parameters, very particularly the sperm, to assess the fertility of the male partner. So this semen analysis, the first step would be collection of the sample. This is very, very important. There are different methods for collection of the sample. The first one is masturbation, and this is considered to be the best method. One has to keep in mind 3 days of abstinence should be given before collection of the sample. This is very, very important. Otherwise, the values will be wrong. And the abstinence should not be more than 7 days. If it is more than 7 days also, the parameter of the different constituents of the semen can also get hampered. Therefore, masturbation is the first one. First method, one should be very careful. The semen should be completely collected into a clean cup. The cup is very important. It should be sterile and clean. If you wash the cup with the soap, etc., the container with soap, etc., and dry it, little amount of soap may be remaining. and that is enough to kill all the sperms, and you may get a wrong result. Therefore, a very sterile, clean cup is very essential for collecting the sample. The second method is the condom method. In condom method, silicone condom is used. These are the special condoms, not the regular condoms. There is no lubrication used in this. So this is the second. The third is coitus interruptus. Just before the ejaculation, the penis is drawn from the female partner and the sample is collected. Sometimes what can happen is the person may not have any sperms passing into the semen. In such a condition, even the testis may be surgically opened, a biopsy could be done, and the sperm, if at all present, could be extracted, and that can be used for in vitro fertilization. So these are the various methods of collection. But one thing we have to keep in mind is during collection, the collecting container should be very sterile and you should not have anything inside that. Otherwise, the semen analysis will be wrong. The second thing is the whole ejaculate should be collected, because in the initial part, more amount of sperms will be present. Next, it would be different fluids that will push this sperm forward. So if first 2-3 drops are missed and you collect around 3 to 4 ml of semen, then also you will get very low semen, you will get very low sperm count. Therefore, very important is the whole sample has to be collected. So once the sample is collected, it should be kept at 21 degrees centigrade or to our body temperature, and immediately it should be sent to the laboratory. Why it should be sent to the laboratory immediately? The reason is that within 30 minutes, it will undergo liquefaction if it is normal, and at the end of 30 minutes, the evaluation should be done if the sample is liquefied. Therefore, immediately it should be sent. And when we are sending, the temperature should be near to our body temperature. Sometimes what happens is when the sample is taken, the sunlight may fall on that, or it may be very cold. So all that has to be avoided. As far as possible, body temperature should be maintained. Now, what is very important is all these evaluation that we do with these semen was explained in Ayurveda thousands of years back. It is well documented. So, there's some problem going on, I think so. No. Audible, madam? So when we go through this Reto Pariksha, I said there are Penila, Tanu, Ruksha, Vivarna, Putipuya, Pichila, Anyadatu Samsrishta, and Avasadi. These are the various Shukra Dushtis that are mentioned. And we go through the classics, we find these doshas, Vata, Pitta, Kapha, Raktadi Dhatu, and Vata and Kapha responsible for these Shukra doshas. Now, today, when we are doing semen analysis using the modern technology, how to understand all these Shukra doshas. A lot of work is done at IPGT and RA previously, and when I was doing my infertility, so we were following all these techniques. The first one is a Fenila. So what we do is the semen that has been collected, when after it undergoes liquefaction, we take a small frothing instrument which would force out air, and that air is passed through the semen. And when it passes through the semen, there is bubbling that takes place, and we will keep that semen for around 5 minutes. Within 5 minutes, all those small bubbles which are formed on the semen, they will completely vanish. And these bubbles will be around 1 centimeter diameter, and they'll be stable for not more than 5 minutes. So if they are more than 5 minutes, then we identify that there is some abnormality in the semen with respect to viscosity, etc. And there is Fenila Shukradushti. The second one is Tanu Shukradushti that has been explained in the textbooks. So the semen would be translucent. Usually it is not translucent, it is more dense. If the semen is very thin, it would look very translucent. And when it is very translucent, it may be because of the different constituents of the semen, which are very low, or the sperm concentration may be low. So then we call it as Tanu Shukra Dushti. The third one is, I told you, the seminal vesicle. About 80% of the secretion of the in the semen is from the seminal vesicle, and the pH of this is around 8. It is alkaline. And sometimes if there is any abnormality and if this pH goes more than 8, then we consider it as Ruksha Shukra Dushti. Under such high pH condition, the integrity of the sperms in the semen cannot be maintained. So this, if the pH is more than 8, then we refer it as Ruksha Shukra Dushti in the present days with respect to semen analysis. Now, after the semen is completely diluted, we'll pour the semen into a test tube, and then we'll look into the color of the semen. And the normal color is said to be grayish white in color. And if this color is discolored, in the sense if there are any other colors which are very pathological, like Aruna Varna, Pita Varna, Shukla Varna, then we say that the patient is suffering from Vivarna Shukra Dushti, which is identified as Pittaja Reto Dushti. And when we take the semen and put it into this slide, and when we study it under the microscope, then we can see the sperms. You can see the sperms with the head as well as a long tail, a thread-like tail. In between, you can also see plenty of pus cells. If these pus cells are more than the physiological limit, then that is pathological. And this is identified as Potipuya Shukra Dushti, and it is one among the Pittaja Shukra Dushti. So all these are practically, all this can be done even today with respect to semen analysis. The third one is Kafaja Reto Dushti. The Kafaja Reto Dushti here, if present, the semen would be Pichila. Now this is assessed by two methods. One is we take the semen, which is liquefied, in a pipette, and we try to drop towards the gravity, and if a thread is formed, and if this thread is more than 2 centimeters, some say 2 to 5 centimeters. If it is more than that, then we say that it is pichila. The viscosity is more, and that is abnormal. The second method that we do is we take the semen, which is liquefied, in a test tube, and then we put the glass rod and we mix it well, and we take the glass rod, we pull the glass rod very slowly out of that semen sample, and when it is pulled out of the semen sample slowly, if a thread is formed, which is 2 centimeter and more, then we say that the viscosity is more and the patient is suffering from Pichila Shukra Dosha, which is Kafaja Reto Dushti. The next one is Raktadi Dhatu Samsrashta Reto, or Anya Dhatu Samsrashta Reto Dushti. So this happens when there are other cells like blood cells, RBCs, or could be the amorphous contents, or could be the epithelial cells. If these are present in the semen, and if they are more than the normal physiological limit, if it is reaching the abnormal physiological limit, then if it is more than the physiological limit and if it is abnormal, then we identify that as Anya Dhatu Samsrashta Shukra Dosha. And this is identified as Anya Dhatu Samsrashta Shukra Dushti. When there is involvement of Vata and Kapha, we say that the patient will suffer from Avasadi Shukra Dushti. Here what happens is the Shukra does not undergo liquefaction. It will remain as a coagulum. As I have already told, the semen is coagulum because lot amount of secretion is from the, it is from the seminal vesicle, from the seminal vesicles, and only a very little amount from the prostate, around 20%, and very less from the testis. And therefore, this 80% of material from the seminal vesicle is very thick. It is coagulum, and it has to be broken down by the proteolytic enzyme which is present in the prostatic fluid. And if there is some problem there, the semen will not get liquefied, and the semen will be very thick like a coagulum. And even after waiting for 30 minutes or 45 minutes, when the semen is not liquefied, if you take that such a semen and drop it into distilled water, instead of the semen drop disintegrating into the distilled water, if it sinks to the bottom, then we identify it as Avasadi Shukra Dushti. Therefore, all the parameters that has been told in the Ayurveda textbook could be practiced even today with respect to modern semen analysis. So today when we get a semen analysis report, first appearance will be written. Grayish white is considered to be normal color. So we say it is Shukla, etc. in Ayurveda. And if there are abnormal colors, then it could be yellow if it is having Pitta Dushti. It could be milky white if there is Kapha Dushti. And when we look into the viscosity, Ayurveda says it should be Kshaudra Niba, Taila Niba, etc. is being told. And if it is more, then we identify that there is Pichilata. So I told you we put the glass rod into the semen sample, and when we pull it, if the thread that is formed, it is more than 1.5 to 2 centimeter, then we say that there is more viscosity. And volume, the volume is 1.5 to 5 ml. If it is more than 5 ml also, it is abnormal. I'll tell you in the next slide. So if the volume is less, then we identify it as Alpa Shukra dosha, or we call such condition as Alpa Shukra. And if the pH, which is told in the modern semen analysis report, if it is the normal is 7.1 to 8. If it is more than 8, then we call it as Roksha Shukra Dushti. Now there is one more that is Grantibhuta or Avasadi Shukra Dushti. We have already discussed the liquefaction time. It should be 30 minutes. If it is more than 30 minutes, then that semen will remain as a coagulum. We identified it as Grantibhuta Shukra Dushti, and when it is dropped into the distilled water, it does not disintegrate or mix with the distilled water, rather it sinks. We call it as Avasadi Shukra Dushti. The next parameter that we find in the modern semen report is the movement of the sperm. Some of the sperms, they will run very fast. We call it as rapid linear progression, and some will move forward slowly. We call it as sluggish linear progression. Some of the sperm are alive, but they will not move. They'll remain in the same place. They'll be shaking their tail or head or some or things. They exhibit things like that, and we call it as non-progressive motility. Sometimes it will be encircling in the same place. All that we call it as non-progressive motility. Some sperms, they remain immotile in that place. So we call such as immotile motility. So all these can be present if there is problem in the liquefaction time and if there is more viscosity, which we have already discussed. And this is equated to Grantibhuta and Avasadi Shukradushti. I told there is some amount, very little amount of epithelial cell or amorphous matter, or there could be small amount of RBC, very small, or 1 or 2 pus cells, maybe physiologically allowed. But if they are in large number, then we can term that in the semen report. If they are in large number, then we call it as Anya Dhatu Samsashta Shukradushti. So all those criteria that is explained in Charaka Samhita in Chikisasthana chapter number 30 can be evaluated in the modern semen analysis. So when we go for modern semen analysis, I think I missed yeah. When we go for modern semen analysis, these are the 4 broad heading where we do the test. One is macroscopic examination, microscopic examination, microbiological examination, and biochemical examination. So any semen analysis will have these 4 broad areas to be covered. And when we go for microscopical examination, we will see the volume. Second is the appearance. Third is the liquefaction time. Fourth is the pH and viscosity. We have discussed about this, but how it has been done in the laboratory, which I would be explaining. When the semen sample is collected and when it is liquefied, we take that semen sample in a special test tube where there are markings. You can see those markings, which will show how many ml the sample is present in the test tube. So we'll drop the semen, we'll empty the semen sample into this test tube and see what is the volume of the semen. And these are the calibrated test tubes. If the volume of the semen is very low, then I said 80% of contribution to the semen is from the seminal vesicle. So if the seminal vesicle there is a blockage, then in such a condition, the volume will be very low. So we should think about the seminal vesicle disorders there and treat accordingly. And on the other hand, we should not be very happy if the semen sample is more than 5 ml. If it is more than 5 ml, then it is not physiological and normal. Rather, it is this semen sample is contaminated by the urine. Because the passage for the semen as well as urine is the same past the prostatic urethra. What happens is when the semen is passing through the genital tract, the sphincter at the bladder, at the neck of the bladder is held tight so that the urine is not let into the semen sample. But if there is some disorders where the where the neck of the bladder is having some pathology in the sphincter, then the sample may be contaminated by urine. In such condition, the volume could be more than 5 ml. Therefore, in such a condition, we should repeat the test once again. The color we have already discussed, the normal color is grayish white. Why it is grayish white? Because it has got high amount of protein. The semen has got high amount of protein and there is lot amount of sperms. This gives it this characteristic grayish white color. And sometimes this color may not be grayish white. Sometimes it could be little light yellow also. That is also acceptable, but not very dark yellow, because if it is dark yellow, or sometimes it could be green, sometimes the semen may have a golden color. In such a condition, the diagnosis should be prostatic infection. If there is an infection of the prostate, then this could be the color in the semen. If we see the color of the semen as yellow, green or gold, then prostate evaluation has to be done. The first method would be to ask the history, etc. And then we can go for perrectal examination and examine the prostate. If the color is yellow tinted, then if the volume is more, then there is urine mixed with the semen. And if the semen is very thick, clumpy and jelly-like, then we should think about the male hormone deficiency, very particularly the testosterone. And if the semen has got red color or dark brown color or sometimes pink color, then we should think about bleeding that is happening in the genital tract, particularly in the seminal vesicle and the prostate gland, that has contributed to these color in the semen. So by looking at the color itself, we can identify the disorder. So this color evaluation during the semen analysis is very important. The next parameter is liquefaction time. I told the semen 80% it is seminal vesicle. It is a thick coagulum and there is proteolytic enzyme in the prostatic fluid, which will break down this coagulum and it liquefies. And this should happen within 30 minutes of semen collection. And if it is not happening within 30 minutes, then it means that the protein kinase which is present in the seminal vesicle is taking upper hand, and the proteolytic enzyme which is present in the prostate has failed, or the amount of prostatic fluid in the semen is low. There is some problem in the prostate because of which the liquefaction has not happened within 30 minutes. Hence, if you see any problem in the liquefaction time, you should think about different prostatic abnormalities and you should evaluate accordingly, and very common is prostatitis. So this is about the liquefaction time. The next parameter would be the acid and base balance. I said the prostatic fluid is acidic and the seminal vesicle fluid is alkaline. When they mix together, a pH of 7.1 to 8 is maintained. Imagine there is no prostatic acidic fluid reaching and only seminal vesicle fluid is there. In such a condition, what can happen is the pH can rise, and if the pH is more than 8, then that is identified as Ruksha Shukradushti, and in such a pH, the sperms are not viable. They are not viable. A higher pH may indicate even infections also. So a pH which is outside the normal is always harmful to the sperm. So we have to look into the pH. This is also very important. And this is equated to Ruksha Shukra Dushti, I told in Ayurveda. The next one, viscosity. We have already discussed how we evaluate that. We have to estimate the viscosity by measuring the thread that is formed. We'll take the glass rod, dip it into the liquefied semen and slowly lift it. If the thread that is formed, if it is more than 2 to 5 centimeters, we say that the viscosity is more. You can see on the diagram there, the thread which is formed is very long, which shows the viscosity is more. And if viscosity is more, the sperm cannot move in that semen. Therefore, the motility will be hampered. If motility is hampered, then the RLP, rapid linear progression, and SLP, sluggish linear progression, will be hampered and it will lead to infertility. Therefore, this also plays a very important role during semen analysis. The second group of tests that we'll be doing is the microscopical examination. Here, what we do, we collect the semen, we look into the volume which we have discussed already, and then we take a little amount of semen, liquefied semen on the slide, and then we put the cover slip and we keep it under the microscope and we look for the motility. And under the microscope, you will see a wonderful universe where you can see plenty of sperms running very fast. We call it as rapid linear progression. Some they run very straight but very slowly. Which run straight and fast, we call it as rapid linear progression, RLP. Some run straight but slowly, we call it as sluggish linear progression. Some they'll be very lazy, they'll be staying there, turning around, moving their head here and there, or moving their tail, but they are not moving. We call them as immotile. They are, some are immotile. And the next parameter that we'll be looking into is the shape of the sperm. The shape of the sperm, as we have studied, there is a head, it has got a cap, then a neck, and then a long tail. But there are very many abnormalities in the morphology, and these abnormality in the morphology, is responsible for infertility. So we'll be studying that. And finally, we'll be looking the number of sperms, because they are key for the fertilization to happen. So we'll be counting the number of sperms. It should be at least 20 million per ml. So that is, we say, the concentration of the sperms in the sample will be analyzed. For this purpose, we may use the microscope and the Newberg's chamber. For this, we may use the Newberg's chamber as well as the microscope, which I'll tell in the next slide. In 2010, the normal sperm count according to WHO is 15 million, which was very high previously, which has reduced now, which shows the fertility potential of male is getting compromised. So this particular evaluation of sperm count could be done by using a hemocytometer, and there is something called as ejaculate count. So what we do is, first the semen sample which is liquefied, we have seen the volume. So how many ml? Imagine 3 ml. And in 1 ml, if the count is 20 million, so in 3 ml, it would be 60 million. So the ejaculate count would be 60 million in one ejaculation. This is how we do. And if there are no sperm seen in the sample, we call such a condition as azoospermia, where there is complete absence of spermatozoon. And if the sperm count is less than the limit that has been specified by WHO, according to WHO 2010, it is 15 million per ml. If it is less than that, then we call it as oligozoospermia. And if it is more than 250 million per ml, we call it as polyzoospermia. Now, if there is low count, then we should think about chromosomal disorders that could be present, or in the vas difference or in the epididymis, there could be some blockage. For example, the patient, if they have mumps, the mumps happen in the parotid gland, but that will affect the testes, particularly the epididymis, and there could be, in such a patient, there could be blockage in the epididymis. If the patient is having tuberculosis of the genital tract, in such a condition also they will have the affliction. In all these conditions, the count may be low because of the obstruction. Sometimes some drugs are also responsible, like cimetidine. Such drugs are also responsible for temporarily reducing the sperm count. Some antibiotics also reduce the sperm count. The radiation therapy reduces the sperm count. So there is a long list. Even the deodorant also will reduce the sperm count, and this could be may not be permanent. Sometimes it could be only temporary. Therefore, we should repeat the semen analysis before we come to a conclusion. With only one semen analysis report, we should not come to a conclusion. So multiple semen analysis report, at least 2 to 3 at a gap of 1 month should be done before we come to a conclusion regarding the parameters in the semen analysis. So this is what I told. Newberg chamber, you know this Newberg chamber. Counting with the Newberg chamber is very difficult. I don't say very difficult, but it is difficult because you have to dilute it. If the sperm concentration is more, then the dilution fluid should be more. That is 1:20 dilution is done. If the sperm is very less, if Tanu Shukra Dushti is there in such a condition, then dilution with the semen diluting fluid is done less, and then you fix the sperm and you count the number of sperm under the microscope. And then there are complex calculations that has to be done, which will give you the number of sperms, or the sperm count in the sample. So there is one more method, possibly you may be knowing it, that is macular counting chamber. The counting the semen or sperm count can be easily counted using the macular counting chamber. Here in macular counting chamber, you can see in the diagram, one drop of the liquefied sperm is directly taken, no dilution, nothing. It is put in the area, in the center area, and the cover slip is put. It is kept under the microscope and it is read. The reading is taken. So imagine you can see 20 sperms under the microscope. Then the calculation is very easy. You multiply with those many million per ml. So you have seen 20 sperm, then the count is 20 million per ml. So this method is very quick, very easy also, and you can get a better result also using the Mackler chamber. The advanced technique I'll tell at the end that could be also followed nowadays. The next, we are talking about the sperm motility. I said the sperm motility, there are different, the sperm can move very fast and very straight. We call it as rapid linear progression. Sometimes it can move slowly and straight. We call it as slow, sluggish linear progression. Sometimes they do not move, only they stay there and they shake their tail or head. We call it as non-progressive. Some do not move at all. They are immotile. If there should be very successful result, at least 80% of the sperm should show forward progression in a normal semen sample. So what we do is we take one drop of the semen and we put it over the pre-cleaned warmed glass slide, and we keep it, we put the cover slip and we keep it under the microscope, and we see under 40x the movement of the sperms, and we gauge whether it is RLP, SLP, NP or immotile. The next would be the sperm morphology. This is very important. We have studied the sperm has got a head, the neck as well as a tail. Sometimes what you can see the abnormal sperm where there is a big head, double head, a small head, elongated head. There could be two tail or a coiled tail. All these are abnormal and that will not bring about conception. So nowadays in the semen sample, the morphology is so low that the WHO says if 4%, only 4% of the sperms also show normal morphology, they say we can take it as normal. So this shows that the fertility potential of male is decreasing. So this is a diagrammatic representation. If there is abnormal sperm morphology, it would look like this. You can see the first one, it is normal. Sometimes there could be two heads. We call it as double head. Under the microscope, when you see, sometimes you can see a big head. This is also of no use. Some you can have an irregular head. We call it as amorphous head. Sometimes the head may be very small. We call it as pin head. Sometimes the head may be tapered. We call it as tapered head. Sometimes the neck, the head in between may be constricted. We call it as constricted head. In some sperms, they may have two tail. We call it as double tail. And in some sperm, the tail will be coiled and it cannot move at all. Such sperm cannot move. And the next one, there is no tail, only head and neck is present. We call it as spermatid. So if there is abnormal morphology seen during the semen analysis, then we should repeat this semen analysis at least after 2 weeks or after 4 weeks. 4 weeks is better because sometimes these changes may be temporary. It may not be permanent. So a repeated semen analysis has to be done. The next test, most important, is sperm viability. The sperm should be alive. Only if it is alive, it can move and it can reach the ovum and fertilization can be brought. So this has to be determined. For this, what we do is we take the vital strain, eosin Y, and we stain the sperms. If the sperms are dead, I repeat, if the sperms are dead, they will absorb the stain and they will look pink. You can see the last slide. The sperms look pink in color. All those are dead stains, the dead sperms which are stained. The one which are alive do not take the stain. You can see the first slide, the live sperm which has not taken the stain, but the dead sperm which has taken the stain. So the viability, normally about more than 58% of the sperm should be alive or viable to say that semen is potent enough to bring about fertility and conception. I was talking about the bulbourethral gland in the beginning and told about the agglutination. So agglutination of the spermatozoa, in the sense one of the spermatozoa will stick to another spermatozoa. And if this particular phenomena is happening, it indicates that there is immunological factor for infertility. Please note it down. If there is agglutination present, it suggests there is immunological factor in infertility, and that immunological factor has to be even further evaluated by further immunological test and has to be treated accordingly. I'll show you these photos, figures. or diagrams rather. These are the various patterns of agglutination. You can see the head touching another. We call it as head-to-head agglutination. Second, you can see various tail touching each other and remaining entangled. We say it as tail-to-tail agglutination. Sometimes the head is touching the body or the tail. We say head-to-tail agglutination. So in this manner, different patterns of agglutination may be present. If you see this under the microscope during semen analysis, we understand that there is immunological abnormality. The last one, very short, just before the last one, there is biochemical analysis, which quickly I'll wind up. We have to look for the fructose. If fructose is present, I said the fructose is present in the seminal vesicle. If fructose is absent, it means that there is some problem in the seminal vesicle and the seminal fluid has not come. In such a condition, the volume of the semen will be less. And when we evaluate the fructose should be at least 3 mg per ml. If there are too many amount of immotile sperms, then it may indicate that there is no fructose in the semen, because fructose is the one which gives energy for the sperm to move. So too much immotile sperms, then you should think there is some problem in the seminal vesicle fluid where the fructose is very low, and that has to be treated accordingly. The next is the acid phosphatase, which is present in the prostatic fluid, has to be also evaluated. This could be present in the large amount. This is very important in case of sexual assault. In such cases, where in jurisprudence, this is one of the important substance, acid phosphatase, which is evaluated to catch the culprit. The last one slide I have for the microbiological analysis. So sometimes the infertility may be due to a urogenital infection, some infection in the urinary tract or the genital tract. And 15% of such conditions lead to infertility, or 15% of infertility is due to such conditions. So this may be due to the bacteria, and usually this bacteria may be present in the genital tract, or sometimes it is present in the prostate. So prostatitis may be responsible for this. So you can ask the history. If there is some problem connected to the prostate, then go for the clinical examination of the prostate through rectal examination. This can also be done, and we can say that we can assume that there is prostatitis clinically. And in such a condition, we can go for microbiological evaluation, because that bacteria will be present in the semen. That semen can be subjected to culture and sensitivity. I'll not talk about sensitivity because it deals with antibiotics, so I'm not touching that sensitivity part. So culture will be done and the bacteria could be found. And likewise, we can treat with Ayurveda also using different medicines that will work on this particular condition. So here, a small example. If you open the modern semen analysis report, you can see the 3 reports that has been shown. And the 3 of the report, the volume is towards the lower physiological limit, that is 1.5 ml. It is okay. But the liquefaction time in the 3rd report is more than 1 hour. Then we can diagnose such a condition by Ayurveda as a Granthi Bhuta Shukradashti. And the viscosity is increased in the first report, then we can diagnose such a condition as Atti Pichila Shukradrushti that is present. In the 3rd report, the pH is more, that is more in the sense it is 9. So we can identify it as Roksha Shukradrushti. In all these conditions, the sperm count, you can see it is very low. It is 5 million, which is very low. So we consider this condition as oligozoospermia. We call it as Kshina Shukra. And this is one important cutoff references as per WHO from 1980 to 2010. See the volume in 1980, 2 ml was normal. Today, 1.5 ml also is accepted as normal. Sperm count more than 20 million was required in 1980. Now today we say 15 million is also okay. And now they are thinking of reducing it to 12 million. And the total motility, in 1980, they said 60% should be motile. Today, if it is more than 40 million also, it could be total motility is accepted. And progressive motility, in 1987, progressive motility was 25%. And it was rapid linear progression, A. Rapid linear progression should be more than 25%. But today, from 2010, even rapid and slow linear progression, both together, if it is more than 32%, it is taken as normal. In the sense, the fertility potential of male is decreasing. So also the vitality has reduced from 75 to 58. Morphology, see, in 1980, 80.5 was considered to be normal. Today, even 4% if sperms are normal with respect to morphology, subjected to few of the conditions, it is considered as normal. So all this shows semen analysis, knowing semen analysis is very important because male infertility is at rise and there will be plenty of patient coming for evaluation at that point of time for interpretation. This semen analysis is a cornerstone and everyone should know about this semen analysis. Latest what we have is computer aided semen analysis. We call it as CASA. Here the semen is put under the very high sophisticated microscope and it takes digitalized photos or images of this or the video of this, and this is studied at a speed of 60 frames per second in the computer, and the computer will study each of the sperm, its motility, then its morphology, and a very precise, very specific report without any human error can be generated using this CASA. You can see the different instruments today. It is very costly, but it will give you very, very perfect semen analysis report compared to manual, because manual human error could be present or other error could be present, but in this it is very perfect, but it is very costly. With this, I think we are running short of time. Thank you for patient hearing. If you have any questions, I'm ready to take the questions.
Thank you, sir. Thank you very much, sir. Anyone have query? So they can raise your hand or put into chat box.
Any queries? So I was a part of IPGT and RA Jamnagar way back in 2009 and 2010. I have most respected Darshana Pandya madam, who was one of my teacher, who was guiding there along with the other stalwarts in the department. So it is a great honor to present in front of my teacher. I thank my teacher, Darshana Pandya madam, for this opportunity. I thank Chinmay madam. And I thank all of you for the patient hearing. If you have any questions, I'm ready to answer your questions.
Okay, sir. So I think there is no any question. So now I am very much thankful to everyone for making this episode very successful. First of all, I am very much thankful to our beloved, respected Director Madam, Professor Tanuja Nesri ma'am. I am also very much thankful to Dr. Darshana Pandya Madam, our HOD Department of Rognidan, for her constant support and guidance. And I also thankful today's our esteemed guest speaker, Dr. Ajantha sir, for his insightful speech on this particular semen analysis topic. Because sir has covered all the aspect, Ayurvedic aspect and modern, both the aspect. And sir, you have very good made interpretation of Ayurvedic parameters with modern parameters. So really it was very insightful lecture, sir. Thank you very much, sir. I also thankful to each and every faculty members and my dear students and all the participants for patient listening. Thank you. Thank you very much. Have a nice
Thank
day.
you.
Thank
Thank
you,
you,
sir.
madam. Thank you, one and all. Thank you.
Thank you.